Hello everyone, this is Fire Chief Paul Dow with Albuquerque Fire and Rescue. This podcast is designed to bring you helpful training and best practices and some additional resources that you can access from anywhere. So thank you for joining us and enjoy today's episode.
Albuquerque Fire Department, what's the address to your emergency?
I have somebody who is having an asthma attack, respiratory distress, and is collapsed.
Okay, how old is he?
17 years old.
Is he awake right now?
William, you awake? You with me? He's unresponsive. He's hunched over, still breathing.
He's still breathing, okay.
Yeah, there
Is
you
he
go.
changing color at all?
Right his head. Sorry?
Is he changing color at all?
We're going to take a look. How's his color? You can lay down, buddy, okay?
Okay.
He's unconscious.
Okay, well, why don't you just monitor
Monitor his breathing.
Monitor his breathing. I'm going to
Get his glasses on.
We're coming lights and sirens right now, okay? If anything changes.
Okay, we're in the driveway.
Okay,
At that
perfect.
address.
We'll be right there.
All right, I'll keep you on speaker.
Okay, I'll be right back, okay? Armed Agent 3 Rescue 3 needs to be in the driveway. Crossing Constitution and Hannett, 17-year-old male, asthma attack. He's not alert, 6 Delta 1. Princeton Drive Northeast, 6 Delta 1, Rescue 3, Engine 3.
Hey everybody, welcome to another AFR podcast. I got Dr. Pruett again, and we're right in the middle of our respiratory series. So again, we're doing a series on all the different respiratory emergencies you could come across. Today we're gonna be at the station. We're gonna sitting around doing dishes, and you get dispatched out for a 6 Delta. You got a 20-year-old female, and the roommate just walked in and said she's having trouble breathing, but she's not really sure what's going on with the patient. That's all you know at the time, so you get en route, and as you're going to this call, alarm room calls you back and says that this patient has now gone unconscious. So that's all you know. You got a 20-year-old female, trouble breathing initially, and now she's unconscious. So you have any initial thoughts on what to suspect maybe when you get on scene? Is this narrow it, or is it still pretty gigantic?
This is a pretty gigantic possible etiology of what's going on with her. I would come back to my 5 causes of difficulty breathing, which would be head, heart, lungs, blood, or musculoskeletal. Probably in a younger patient that's not breathing normally. Obviously, just given the environment that we live in these days, I'm going to think about possible overdose. Could be hyperventilation. She's also one of the most life-threatening things I would think of would be a pulmonary embolism.
Okay.
Or possibly asthma attack, or maybe allergic reaction.
All right, so we've all seen the heroin overdose. We're going to have slower respirations. We're going to have the pinpoint pupils. We're going to have maybe some sonorous respirations as well with the tongue blocking the airway.
Mm-hmm.
So as you're getting to the scene, if you're suspicious of that, if you see those signs and symptoms, then that's going to lead you down that route. Now, if you see something else, maybe the person's breathing faster, it might change what you think.
Absolutely. I would still consider it in a young person who is having difficulty breathing and isn't completely conscious, but it's very important not to narrow in on just opiate overdose because it's so common. It's easy to go right to that, but we need to keep a broad differential with her.
Okay. So as you walk in, you see the patient. She's on the ground. She is unconscious. You're trying to gather any kind of history from the roommate, and she's like, I don't know what happened. I walked in, and she was, she couldn't even talk to me. She was just struggling to breathe. You're like, does she have any kind of history? And she's like, I don't know, but I know she's got an EpiPen, but I'm not sure what's wrong with her. And then as you're walking around the apartment trying to get some clues, you see that she's got an inhaler in her room. But now you got to get to the patient. So this patient is unconscious. You check her pupils. There are 4 and Pearl, and as you're listening to lung sounds, you notice some audible stridor, and you can hear some wheezing going on in the lungs, and she's breathing a little bit, maybe 28 times a minute.
Okay. So now I would think overdose would be lower on my differential for her. Anytime I'm kind of confused and not sure what's going on, I always come back to the basics and just ABCs. So my first move would be to address her airway. You said it sounds like she might have some obstruction going on with the stridor and the drooling and the increased respiratory rate. So I'd try to position her, do a little jaw thrust, see if we need to bag her and give some supplemental O2 if that makes a difference in her presentation. And then see how she's breathing. You said you heard wheezing.
Yeah, you hear wheezing, and you're able to get a sat on there. She's sat in like 75 right now.
Okay.
And yeah, so you're able to start bagging.
Okay, so I'm back to the basics. I'm doing ABCs. I'm just trying to fix the problems as they show up. She's hypoxic, and we've adjusted her airway. We're giving her supplemental O2. We're bagging her. Is anything helping?
It doesn't seem like it. As you're bagging, you're not seeing good chest rise and fall.
Okay.
Okay.
The other clues that you gave me with this girl would be the fact that you saw an EpiPen. I would maybe ask about possible allergies. Could this be anaphylaxis? Did she get into something that maybe she's allergic to? And considering that and hearing the wheezing, I'd still try to gather more history and information at this point as we're still addressing the airway.
Okay. Yeah, and the roommate, she just walked in, and she has no idea. She hasn't talked to her roommate all day. She just walked in. She's struggling to breathe, and then she ends up going unconscious, and now she's on the floor. And
Okay.
that is all the history that you get.
Okay. And nothing is improving with our
Yeah, your interventions are, not really helping. The BVM is, say you're able to get an MPA in there for the, what you thought might have been causing the stridor. And then you start bagging, and it's just, you're not seeing good chest rise and fall. Your lung sounds, you still hear wheezing.
Okay. And then I would anticipate, what's her blood pressure? Is she hypotensive? Probably.
Yeah, you are able to take a pressure, and she is hypotensive. You also expose, and now you see some hives.
Okay. So at this point, I'm worried about anaphylactic shock. So I would, with stridor, wheezing, hypotension, I would go ahead and give her epinephrine.
Okay, and so the dose is going to be 0.3 IM of the epi. Okay, so in this situation, we had a few more signs. So we saw the hives and decided to go ahead and give the epi. What if there's a person out there not as comfortable with it, maybe afraid to give the epi, or it took them, too long to draw it up, and now this patient starts to brady down and actually goes into cardiac arrest? What do we do on that patient?
Okay, this is a tough scenario.
Yeah, the worst possible patient.
Yeah. I had a boss one time that told me in anaphylaxis, you can either give epi early and give the small dose in the muscle, or you can give epi later and give the massive dose through the IV. And this is kind of that situation where if we didn't get the small dose on board early enough, we're still thinking this is the same problem, but we're a little bit behind the 8 ball with her starting to arrest now, and this is clearly a respiratory arrest, so we need to secure her airway and fix the underlying cause of why she's arrested.
All right, so we go, we're trying to get the airway under control. We got an MPA in so far, and we're bagging, and we're just not getting very good ventilation going on. We've got wheezing. We still have the stridor, and you don't hear a lot of air movement going on.
So you're making this even tougher. This is like
now
the worst.
What?
Okay, so what you're telling me is we have a patient who's in respiratory arrest, and I can't oxygenate and I can't ventilate. Is that what I'm understanding?
Yes.
Okay.
Ventilation is ineffective.
In my mind, you're telling, by those criteria, in a patient that I can't oxygenate and can't ventilate, this is a patient that would need a crike.
Okay.
Assuming I can't get an airway, I would probably take a look first to see. But given
so
the
take
stridor,
a look. Maybe it's possible to still intubate. An LMA is not going to do any good. If the bagging's not doing any good, the LMA is not going to do any good. Yeah. So you'd say you might take a look, see if you're able to pass a bougie, possibly, with that closing airway.
Possibly, yeah. If you've got upper airway obstruction due to edema, it's going to be really difficult to identify landmarks. And even if you can try to get a bougie through, that's great. You're going to probably need a smaller size ET tube. But this is a patient who's already arrested, and I wouldn't waste a lot of time trying to figure out what I'm looking at in her upper airway if I'm still not able to oxygenate or ventilate. This is absolutely the patient that's, to save her life, she's going to need a crike.
Yeah, so that's why the crike is in our protocol, is for this girl right here, pretty much.
Exactly.
Right?
Yeah.
So everybody out there, paramedics, if you're able to do a crike, you've got to have it, planned out in your mind prior to. I've only actually criked one patient. So probably 5 years ago, I went to a paramedic refresher through the military, and we get to, I was in pararescue. We had a lot of money. We got to go to a lot of cool courses. So I went to Wake Forest, and we had like 8 cadavers that we got to practice on. So we're just practicing crike after crike after crike. And when I came back at Station 16, there was a 19-year-old that crashed his car, ejected like 30 feet, and he had all kinds of facial trauma going on. So we were just a load and go situation. It was really just right at the doorstep. So we load and go, and en route to the hospital, my lieutenant is, she wants to try to intubate first, like you recommended, but there's just a real bloody airway. Suction wasn't helping out. And I was like super eager. I was like, I criked like all these cadavers. So I was super eager on the crike. I had all my equipment laid out. And my plan at the time was I'm going to, identify my landmark. I'm going to use my scalpel. I'm going to make my vertical cut. Then I'm through the skin. Then I'm going to make my horizontal cut through the cricothyroid membrane. Then I'm going to put pediatric Miguel's in to keep my opening, remove my scalpel, pass my tube, and that was my plan. Now, I got all my equipment ready, but the pediatric Miguel's had bounced as we're going down the road, so I didn't have the pediatric Miguel's available. So I had to get the adult Miguel's, put it in, put the tube in. So it was a good crike, but it turns out that the adult Miguel's, they have those big grabbers on the end of it, and they wouldn't come out after I got my tube in there. So we brought this patient into the ER, and he had adult Miguel's hanging out of his neck. And I don't know, it's kind of a funny situation and a tragic call. But
yeah.
Anyways, those are the things that can go wrong on a crike. So have it all planned out. Now, I'm just going to plan on using a bougie. What do you recommend? What's your plan on criking somebody?
I love the fact that you went into that scenario with a plan of exactly how you're going to do it, and you're able to execute it and work around it. I think that's one of the most important things with these like high acuity, low frequency events, is to have run through them in your mind before they happen and be ready to do it. My plan is much like yours. All you need is the 3 things: a scalpel, a bougie, and a tube. Do your north-south cut, your east-west, punch through that membrane, keep your finger in there, get your bougie in, and then put the tube over.
Okay. Yeah, and this is, every procedure that you could possibly do. It kind of helps you as you're going through and checking your bags, for the drivers out there. But, walk it through every possible thing as you go to each compartment. Now you're on the airway bag. Okay, what kind of situations could I be in? Am I good for intubation? Am I good for nasal intubation? Am I good for crike? So you make sure that's an easy way to make sure that you got all the equipment you need, is to do all those mental rehearsals prior to getting them. Yeah,
and deciding which patient you're going to do it in too, because a lot of these I feel like we're afraid to do crikes because it is a surgical procedure, but knowing it's the patient that you can't oxygenate and you can't ventilate, and once you can check those 2 boxes in your mind and you've confirmed that that's the patient that you're looking at, don't wait till they die. If this is a patient, if they're still alive, it's better for them if you can secure that airway soon. It doesn't have to be after you've messed with the upper airway for too long.
All right, now let's back up. So I gave you the very worst situation ever, but what was happening in this 20-year-old patient, and how did it get this bad to the point that she goes into an respiratory arrest?
Assuming this is anaphylaxis, this is a very difficult call because we really had to troubleshoot her physiology in addition to trying to figure out what was the underlying thing to treat. it sounds like with her allergy, what happened is the physiology of anaphylaxis is that allergen is introduced into the lungs, and for whatever reason, the immune system is super hyperactive to this particular, we call it an antigen, which is basically an invader into the body. And the way that the body reacts is just this massive assault. And one of the things that happens is constriction in the airways, mucus production, which can lead to hypoxia. In her case, it also led to a profound amount of vasodilation, which leads to the hypotension and the shock part of it. It can manifest as skin, but it doesn't always manifest with hives. In fact, I think like 20% of anaphylactic reactions don't have skin involvement. One of the systems that we don't necessarily automatically think about with anaphylaxis being involved is the GI system. So a lot of times people, when their body's reacting to something, will either get nausea or vomiting or have diarrhea. Because if you think about it, our gut is one of our major methods of our body fighting invaders with the acid in the stomach, and there's a lot of our immune system is involved in the GI tract. And so in my mind, anytime there's two systems involved, whether it's cardiovascular with hypotension, or it's the skin, which is easy, or GI or respiratory or airway with the edema, once I can, and another important one to think about is neurological status too. So if people get confused or unresponsive, anytime I can identify that I've got two body systems involved, I'm going to define that as anaphylaxis. And in my mind, then the minute I can do that, I'm going to give epinephrine.
Okay. I've also been on less severe calls. So I remember one specifically, the patient and her friend were driving in a car, and the patient somehow ended up eating, like a peanut or something like that. I can't remember the exact specifics, but we showed up and the patient was freaking out. She was like, I'm allergic to peanuts, and I ate something I didn't know had peanuts in it. And like, she's kind of, it seems like super severe at first. Like, everybody's panicky. The friend tried to administer the patient her EpiPen, but she shot herself in the thumb.
Oh, geez.
Yeah. And so it seemed pretty chaotic. But then once we slowed down and started assessing the patient, like, she was sat in 99%. What sounded like stridor, like she was kind of just doing it, like she was like panicking on her own. So she was like, and you could tell that, I don't know, it didn't seem right, so we were like, hey, stop making that noise with your throat. And she ended up just breathing normally, again, sat 99%. This person, I was under the impression at the time, I was like, well, she's got an EpiPen, she's allergic to peanuts, let's just give her Epi. But I was with another medic that was like, well, she still sat and fine. She turned out to slow her breathing down, and she ended up breathing fine. So I think what we ultimately did was not administer Epi. So, that's what I would like to get out of this is, when do you pull that trigger?
Yeah, it sounds like it worked out just right in that situation. In these younger patients that do have airway complaints, I have a lower threshold to actually pull the trigger on Epi. So my trigger is, like I talked about, the two system involvement. So she's telling me that her airway is involved, and like, we know that she's had an allergy exposure, and if I can figure out that there's another system, whether that's wheezing or skin or whatever, then I'll go ahead and give it. With her, it sounded like she just needed some calming things. What you can do to buy yourself some time and kind of tease out what actually is going on is give her the other treatments that we have. So maybe start with some Benadryl, start an IV, give some fluids, think about steroids. And if the fact that you're treating her, if she's kind of making that noise on her own, she should start to stop it because she feels like her needs are being addressed. But if she's still having that complaint, I would go ahead. I'd take any airway complaint pretty seriously. Yeah. And
so maybe we, at least for me, I take that I might need to be a little bit more aggressive with the Epi in the future. It seems like I'm I don't know, a little reluctant to give it. It's not something that we do very often.
We don't do it very often, but I think once you can, in your documentation too, if you can confirm that there are two systems involved, nobody's going to fault you for giving the epi.
Okay.
But we talked about on the other podcast with COPD and when to give epi. This is a little bit of a different pathological process, and usually a different patient population. These are usually younger patients that can tolerate the epi a little bit better, won't have as many cardiovascular side effects, and will have a direct effect on what's going on with the allergy that's causing the problem.
So we're going to give 0.3 milligrams epi IM, and what if they need another dose?
If they need another dose, that's fine. It's better to give, like we talked about, the small dose before you have to give the big dose after they arrest. So I'd give them about 5 minutes after the first dose to see if anything gets any better. In the meantime, be giving them the other adjuncts to treatment, starting your fluids, giving the Benadryl, and then don't be afraid to give that other dose if you need it. And about the time I'm drawing up the second dose, in my mind I'm wondering if I need to just start a drip or do the mini boluses.
Okay. And as we all know, it's a lot easier said than done, right? I just said, we're just going to give 0.3 milligrams epi. So done, problem solved. But when reality is, like, there's a lot more to it. So you've got the epi in this little glass ampule. I remember one time I was in Afghanistan going on like a scorpion sting, and I was trying to draw up epi, and it was the first time I ever did it. And we used to wear these flight gloves in case there were like a fire or something. We had to wear the flight gloves, and trying to break open the ampule, and I just ended up crushing the entire glass thing, and I had to try that one over. So.
Oh man, yeah. We say these things like they're easy to do, but we forget there's lots of steps involved.
Right, and then with epi also, you got to have that put that filter straw on there, because there could be like little glass shards that you suck up as you're
drawing it.
Drawing it up, yeah.
Yeah, goodness, man.
Okay, so that's a 20-year-old female that we have been talking about. Let's move to pediatric, maybe a 10-year-old. Do they present any differently?
Actually, we're seeing a lot more allergic reactions in kids. I think part of it could be attributed to the fact that our food is changing. There's a lot of new additives or chemically modified things that our bodies aren't necessarily used to. Kids can manifest a little bit different than adults in the fact that they might have more GI predominant symptoms. So it's important to think about when you've got a kid with nausea, vomiting that's having a little bit of increased work of breathing, especially the younger ones, like 2 or 3 that can't really communicate with you as well. I always try to have that on my radar. Could this be allergic reaction? Because unless you're thinking about it, you're going to miss it.
Yeah. Okay. And then, so the pediatric dose is going to be what, 0.01?
0.015 is what's in the 0.01 milligrams per kilogram, which in the EpiPen Junior is just the dose. I remember it's 0.15.
Oh, okay. Yeah.
So half the adult dose.
Right, and then it's all going to max out based on their weight. It's going to max out at the 0.3.
At 0.3.
Adult.
Yeah.
Okay. Now, this first horror patient that I gave you, she had an EpiPen and she also had a inhaler. Is there any correlation between allergic reactions and asthma?
That's a fantastic question. Yes, there's patients that actually are more prone to very severe allergic reactions or reactions that are a little refractory to treatment. And one of the biggest patient populations to think about that is asthmatics. Their lungs kind of at baseline are constantly reacting to things in their environment. So they have that excess mucus production. They have the edema in the airways, sometimes the narrowed airways just at baseline because of their asthma. And then you add in an allergen on top of that. And if that worsens that airway edema or the mucus production, or the respiratory consequences, they're going to have a lot more severe reaction.
Okay. And asthma and COPD are also pretty similar, right? So we had a whole COPD podcast, but for a refresher, what's going to be, our start off treatment on this asthma patient?
Yeah. Okay. So if we're moving to asthma, aside from anaphylaxis, Asthma airways are very similar to COPD airways in the fact that they're both, there's obstruction in those airways, whether it's due to edema or mucus or fibrosis or airway destruction. Somehow air is having trouble getting in and getting out. So you'll see the same things in both patient population. You'll see them working hard to breathe. You'll see their end tidal be higher. You'll see them using accessory muscles. You'll see an increased respiratory rate. All of that work and effort is going to moving air across the airways.
Okay. And if the patient, do their inhalers usually work pretty good for them if they have them available?
Inhalers should work well. That's why it's the same kind of process. So we give the duonebs. We use CPAP in asthma patients as well. It's, again, that obstruction that we're trying to give that positive pressure to open those airways. Epi is something we move to a little bit faster in asthmatics than we do in COPDers because that's where the nuances and the reaction come in. But
can you describe maybe a asthmatic patient that might need epi?
Again, I kind of reserve the epi in my asthmatics as kind of a last-ditch throw in the kitchen sink kind of effort before they go into respiratory arrest. My first moves with asthmatics are always much like COPD would be CPAP first, then a duoneb, then the Dex. It's basically the same process. MAG, all of that in order to get air in and out and relax, use every modality I have to open those airways. So the albuterol and the ipratropium is going to act on the different receptors to do the bronchodilation. The Dex is going to decrease the inflammatory response and stop that cascade of edema. And then the MAG is going to work on the smooth muscle to relax it. And then after I've given all that a minute to work, then I'll think about epi.
Okay. A couple things I wanted to bring up. I think it's just, as you're listening, the more times you hear something, the better. So albuterol, again, for an adult, we're going to give 5 milligrams albuterol. The ipratropium is going to be 0.5 milligrams. Our Dex dose is going to be 10 milligrams. And it's IV. You give it over 2 minutes, or you can avoid all that, as you like to bring up, and you just give that orally. Right, so you just draw it up in a syringe and take your needle off and squirt it in there. Is that how you do it?
Yep.
Okay, and then your MAG dose for these patients is going to be
2 grams over 10 minutes.
2 grams over 10 minutes. Okay, and I would like to also ask you about more on the dexamethasone. So, how quick is that going to act? And maybe a little bit more specifics. Is that something we're going to be able to see working on the patients by the time they get to the ER?
Probably not by the time you drop them off at the ER, but I would expect them to look a lot better in the ER because of it. It takes anywhere from, depending on the patient's metabolism, anywhere from 10 to 30 minutes is what the textbooks will tell you. And then those effects from that drug can last up to 72 hours. So really what you're doing for that patient is helping improve them over the next 3 days.
Okay, so all right, let's have an example. 28-year-old female patient. She was running outside, and then she just started having a pretty bad asthma attack, and you have to respond to that patient, and breathing like 40 times a minute. The inhaler is not working, and you get her on a O2 sat. She's down in the 80s, like the low 80s again. Just struggling pretty bad. What are you going to want to do on her?
This is another one of those kind of difficult situations to describe, but I'm going to base a lot of it on how she looks. How hard is she working? How tired is she? My question in my mind that I'm thinking of is that, am I going to move to CPAP right away, or am I going to give her a chance to just do a duoneb and see if that makes her better? This is a patient I might just start with a duoneb first and give that a chance to work. But if it's pretty clear pretty soon that it's not, I'll move to CPAP.
Okay. All right. So wrapping up, I guess, on the topic of anaphylaxis and asthma, do you have anything that we might have missed on these two?
Not that I can think of. I think the biggest take-home point is don't be afraid of epinephrine and anaphylaxis. Once you can define that there's two systems involved, don't be afraid to give it.
Okay. One of the things, if we are riding in with the ambulance and you show up to the hospital and they do something within a few minutes of you arriving, I always take that as that's something that EMS probably should have done. How do you feel about that?
That's probably a good kind of way to look at it or think about it. If it's something that's in your scope and you had the ability to do, it might be a good learning point
so
to
if we
even
brought
bring up with
in,
them.
say we brought in a allergic reaction that we didn't feel needed epi, and we show up to the hospital and they give epi. Learning point, right?
Absolutely.
Or we show up with a asthma patient, we did a duoneb, we didn't do CPAP, they get the patient on CPAP right when you get into the ER, they gave mag, things that we didn't do.
Yeah, that actually is a really good point. And you might, if there's time, to bring it up with the physician at the hospital, like, hey, what triggered you? What did you see in this patient that I missed? And it's a good time to ask or maybe clarify to understand what they were thinking in their treatment.
Yeah, that's my way to learn, if whether it's a trauma patient, whatever it is that we're bringing into the ER, if even something as simple as exposing the patient, this has happened a couple times, but now after I learned from it, I'm like, I'm going to the trauma room and they're going to expose the patient right away. Like I should already do that.
Yeah.
So
yeah,
just learning,
fantastic.
if you show up to the ER and they're doing something immediately, like just take that as they might not tell you messed up, but you probably messed up. So try to learn from it and improve on it in the future. If there's something that they see, I've also been at the other end. We had a really good AAS medic that was real aggressive with the epi in a asthma call. And we showed up and she was like, yeah, we did 0.3 epi IM. We did a duoneb. She was satting in the 70s. Now she's satting 98%. And they're like, oh, sweet. Good job.
Yeah.
And we had given decks already. So
yeah, you basically did everything the hospital was going to do.
cool.
Yeah.
All right. Yeah, I think that's a good maybe closing point of just seeing the end outcome, or even with AAS, like if you're there at fire and AAS shows up and they do they give something like pretty quickly after they show up, like that's probably something that we should be doing prior to them getting
Right.
there. So
Excellent point.
Yeah.
Excellent point.
all right. Well,
All right.
these have been good so far. So
Yeah.
we've got the asthma covered, we got COPD covered. We went through anaphylaxis in this one. Thanks again, Doc, and I
Thanks,
look forward
Andrew.
to the next episode.
Me too.
Thank you.